I'd like to dedicate this presentation not for me. I'm a bloody German, being trained in Germany, worked for 7 years in the UK, and now I'm privileged to work in the Australian health system with abundant opportunities and financial support. I would like to dedicate it to the patients in the UK treated by brave cardiac thoracic surgeons who don't have access to advanced mechanical support beyond the intra-aortic balloon pump. So quickly, now financial disclosure. So one of these patients in the UK, and picture even so this is one of the first patients, one of my first patients in Perth, but now picture the following year in the UK and you meet Matthew. And you're going to go to the emergency department because this is a 68-year-old gentleman who has an aortic dissection and then you get a little bit more extra information that he had 17 months ago, a triple bypass, and likely the entry point of the aortic dissection was one of the proximal top ends of the venous grafts. So he is a little bit slightly overweight, he has a typical risk factor, and you take him to theater, you do what you need to do, you do subclavian access surgery, median stenotomy, retroenteric cardioplegia, add CO2, you want to really prevent and protect the heart, resuspension of the aortic root, you can cut out the aortic dissection because the arch is basically protected, so you do hemiarch replacement, and you implant the two grafts into the Dacron graft, and once you measure the grafts with the Medistim device, you say, well, actually pretty good, let's reperfuse, and it's not lots of bleeding. Hopefully we come off bypass and we get out of theater. However, soon after, the anesthetist tells you, well, the patient is getting more and more vasoplegic, and then you look at the heart, and the heart has a profound right heart failure. So what do? You step aside, you say, let's reperfuse a little bit longer, you do extended reperfusion, you use nitric oxide, maximal catecholamine therapy, and then you look over the chest, over the the curtain again, and you look into the chest, and then you say, what options do you have if you don't have some advanced MCS as a backup solution? Of course, you can go to the bathroom and you can just pray, and then you hope for a miracle. Well, we all know that's not very successful in the majority of the cases. Then someone drops the question about what's about a balloon pump? Well, balloon pump, if you have an ECMO, that's a different story. But now picture you only have the balloon pump. And then you say, well, but it's aortic dissection, we still have the descending aorta, there's still a flap, is it a good idea? There are other centers as well. This is a publication from Marseille, from the French group, and they looked for 151 patients, and then we get an understanding, is it this common? That's not very common, but of course you still have 10 patients. They had some kind of an aortic dissection and they couldn't come off bypass, so 3 were limited to the ascending aorta, 1 reached the arch, and 6 went in the descending aorta. And the outcome was, not ideal, but of course, now picture you only have the balloon pump. What do? You go for the balloon pump. Even so, we know that the survival without any neurological consequences is 20%. You lose patients, it's not an ideal situation. So we come back, and then you can, of course, think about if you don't have an ECMO in your hospital, you can call for help. So you call one of the reference centers we were lucky in Hereford that in Hackfield we were contacted quite regularly, and the Brompton people as well, that you can call and ask for some help. And we got regularly calls from centers around London, in London, without ECMO support, what to do. So, but of course, you need to understand that's not an easy fix. And of course, I was part and the representative of the SCTS for this Shock to Survival, the framework group, which has been published in October 2022. And of course, we represented only one of them, was the SCTS, and what is important and you can download it, it's online available, some kind of critical decisions must be made quickly. You're on bypass, you can't come off bypass. Let's consider that you have been on bypass already 2.5 hours. You reperfuse another 45 minutes. You don't have 6-7 hours to just make a decision, so it needs to be relatively quick. It should be capable of providing rapid support, so it's not only, okay, let's order and then tomorrow. Now you need to have a rapid support to come off bypass, to shift the patient out of theater onto the ICU. And it needs to be available 24 hours a day, 365 days. And of course, and then the last point is what I alluded to, is the transfer of patients into hospital transfer. Yes, you can. If you have a cardiogenic shock patient in the cath lab, you can go there. You implant an ECLS, you can implant the impeller system, and then you can transfer the patient from one hospital to the other, because even if you save a patient on ECMO, central ECMO for instance, your ICU is not well trained. and your ICU nurses are not going to be happy. So you need to transfer a fresh open chest maybe, or a fresh aortic dissection with an ECMO circuit from center 1 to center 2. That's really a challenge. So thinking back again, in every cardiac center, short-term MCS beyond the limb should be available. Always think about this topic, which was chosen by Stefan Schüler. We always think about, what do we have? Some kind of, well, what we did, yes, we used the ECMO. And if you use the ECMO, that's good. You use the venous access with the femoral, and we use the central arterial, the side arm of the diaphragm prosthesis, the anterflow prosthesis. And then we stabilized the patient. Patient went to ICU. 3 days later, we took him back to the theater. And this is, unfortunately, it was not Martin Scorsese who shot this, some kind of video sequence. But you see the heart picked up, and the heart was able to recover, and we could wean off the ECMO. So, but there are other Matthews in this country. And the Matthews have different diseases. And it's, of course, the aortic dissection surgery, complex. If it affects the right coronary artery, you might graft it, but sometimes you don't know if the flow is really sufficient, because if you have a spiral dissection into the right coronary, then even the graft on the right is not going to be always successful. You do aortic root surgery, plus minus infective endocarditis. You do redo cardiac surgery, infarct VSDs, papillary muscle ruptures. If you have the increasing number of adult congenital or complex congenital surgery, you might meet another Matthew in your theater. Cardiogenic shock, is it quite often? No, it's not really quite often, but cardiogenic shock after cardiac surgery is still about 2 to 6%. Keep this in mind, 2 to 6%. So it's not only some kind of maybe every 5 years. No, normally in your unit, you see it once or twice a year that you have a patient who might benefit from advanced support. And of course, look at the literature. The literature is abundant. And of course, they all say the same. ECMO is possible, and you can save patients. The question about how many patients you can save of these patients, the 2 to 6%. And indeed, this is going to be the paper published last October in American Heart Association, in indicating a really nice study. And of course, this is very frustrating because the majority of the enrolling centers were in Europe, but you had even from Australia, but you had none of the UK, and this is because limited access to ECLS after post-cardiotomy for post-cardiotomy treatment. But what is important, the mean age is 65%, and the in-hospital survivor is 39%. So 39%, almost 40% of the patients can survive if you have an ECMO to save the patient's life. Matthew, 40% of the Matthews can survive if you have the appropriate some kind of support. And unfortunately, this is a little bit obscure, but we have seen it before by Alexander about some kind of 1 year survival rate. Once you survive this one, the 10-year survival in a 65-year-old patient is still 65%. This is absolutely mind-boggling. So this is not only that patient leaves the hospital, but then soon after he's going to die in a rehab facility. No, they can survive even long-term for 10 years. And of course, what are the independent factors? We all know, of course, if you have an 85-year-old patient, maybe you consider not to getting him on ECMO. But if you have a young patient, like this, Matthew, then of course you would like to consider taking him on. And then what is important, did you fix a problem? If, of course, you can't fix a problem. If you have an aortic dissection where the coronaries are dissected, and yes, you graft, but you have no flow on the coronaries, what is the likelihood that this patient is going to survive? No, it's not. But if you have a question, and you say, well, I'm not sure, you can stabilize the patient on central ECMO. You can ask VARS, can we take the patient to the cath lab? Can you have give a shot into the coronaries? And if you can stand anything, if you can help us, you can still get the patient out of this misery. So the fact is, it's a very important study from this last study. Well, is it only for the experienced centers, for the centers who offer transplantation and that? In this country, we have 6 centers who can do it. But of course, there are centers who don't. And of course, this is these cohort studies. So if you're working in a transplant center and a VAD center, 41% survives this post-cardiotomy with ECMO. But even if you work in a non-transplant center with proper training and teaching education, still 34% of the Matthews survive in your center if you have this system available. So post-cardiotomy, always think about, this is 40%, but some kind of, again, should be available because we know should is some kind of a nice wording, but the reality is something different. This is a bottle of wine, it's a Welsh wine. It's not Welsh from local, it's Welsh from New South Wales. But of course, look at there's an elephant in the room. Some kind of, and what is the elephant in the room? That only 30%, 13 of the cardiac surgical centers in the UK have access to ECMO. Only 13. Some kind of, the majority don't have access. And of course, for the Germans, they say, well, what it means? Some kind of, well, we have centers, large academic centers, who don't have access to post-cardiotomy ECMO support. So, of course, we can speculate, we can discuss about what is really the reason why we don't have, but of course, one thing which has been picked up by Stefan is about the silence. We shouldn't silence, we need to speak up. And I know that the society is picking up this as a framework and as a position paper in order to address it. And I personally like to think about, it is better not only to think about us as a cardiac surgeons. I believe we need to reach out to our cardiologists, to our anesthetists, to our critical care colleagues, that you basically say, okay, let's get the British Cardiovascular Society involved as well, get the Cardiovascular Intervention Society, include patient speakers who can help us as well to raise the voice in order to fight for Matthews. And my suggested action plan for you guys is all about, you need a joint position paper with a statement, a clear statement of all associated societies, all cardiac units, and this is important, not only these units who have it, and not only these units who don't have it, but of course, I'm really convinced that we need to, as a few privileged centers, like Harefield, Newcastle, these centers, they need to support the underprivileged centers that they get access to this life-saving treatment as well. It's 2024, and we have a system available, a robust system. And I believe you need to fight for these 34% of Matthews. They have a right to have a strong voice. So what we did with Matthew was, yes, weaned off. Was he a flyer? No. With a BMI of 45, we all know that it was a slow recovery. However, he was extubated at day 6, and 20 days later, he was discharged home. And while this is going to be very important, think about that what we can achieve. So I would like to replace the should to needs to be available. So this country and the patients and every cardiac surgeon in this country needs to have access to short-term mechanical support to save patients' lives. And of course, here in the Fiona Stanley Hospital, we have every Thursday, we have our transplant and advanced heart failure meeting. And one rule is at the end, we need to stop with some kind of a happy slide. This is a happy slide. This is some kind of, it's one of our local animal parks. And Matt, it is a koala bear. Koala bear is enjoying a midday nap. We have right now summer, and I want to tease you a tiny little bit about the weather forecast for the next 10 days in Perth. We are really some kind of blessed, but of course, I believe we need to thank, most important, Stefan, to picking up this important topic, fighting for you guys who not really have access to the ACLS support, and I'm very happy to entertain your questions. If you want to contact me, please do so. Thank you.